So we're going to start with diseases of the skin and the subcutaneous tissue. These are your L codes. They run from L00 to L99. So in reference to PDPM, when it comes to skin conditions, we'll start with open lesions. These particular sorts of lesions are not ulcers, rashes, or cuts. Think of skin lesions as a result of some sort of disease, such as syphilis or cancer. Think along the line of Kaposi sarcoma, something along those lines. So if you have a resident who has one of these sorts of lesions, this would map into your nursing category, clinically complex. And of course, these would have to be lesions that were being treated. And this would be something you would have to check off on section M of your MDS, your 5-day, M1040D or E. Foot skin problems or other open lesions of the foot will also impact your nursing category, special care low. Again, that's section M on your MDS. And it can also impact your NTA comorbidity category, and that's 1 point. Same thing on section M of your MDS. So when these, you just want to make sure that when you're coding them, that these are active, that we have treatment orders, and we have the documentation to back that up. Psoriatic arthropathy is an NTA comorbidity category. It's funny, I hadn't really heard of this condition until they started giving us points for it for PDPM. It's not something I had encountered before. Now I'm noticing it more. I'm sure that's just coincidental, but one of those things where you don't really notice it until you're getting reimbursed for it. And this one is one that would have to be on section I-8000 of your MDS, your 5-day. And remember that I-8000 section is your other active diagnoses section. So anything that's on your that's an NTA comorbidity that has to be on that section, you want to make sure that you're sequencing that high so that it gets pulled over. And to look that up, you would start with the term arthropathy and then your sub-term psoriatic, and it gets you to category L40. Pressure ulcers. Nothing has really changed this year when it comes to coding pressure ulcers. One of the things you should be aware of, though, is for deep tissue injuries, DTIs. A couple years ago, we used to code those as unspecified, but now there is a section for those. So these are L89 codes that end in the number 6. So just be careful with those, because that is something I've noticed is some facilities still code those as unspecified or unstageable. You want to be careful with that. So for NTA purposes, stage 4 pressure ulcers will get you 1 point. And that would have to be checked off on M0300D1 on your MDS. And you would also want to make sure that the appropriate L89 code is on your diagnoses list. And make sure that you're coding all pressure ulcers that the resident has. Some facilities, for some reason, don't tend to code the stage 1s, but it is important that we are coding all that are being treated. One of the changes for 2022 coding guidance as far as pressure ulcers is that if during an encounter, the stage of an unstaged pressure ulcer is revealed after debridement, you want to assign the code for the stage that is revealed following that debridement. And for your nursing category, special care low, these are the ones that will impact that nursing category. If you have a resident with 2 or more stage 2 pressure ulcers, any stage 3 or stage 4 pressure ulcer, 2 or more venous arterial ulcers, and 1 stage 2 pressure ulcer and 1 venous arterial ulcer. And all of those say with selected skin treatment, which means that we have to be treating those in order to be coding those. And these are the selected skin treatments which you would see. Pressure relieving chair or bed, that only counts as one treatment though, even if we're giving them both. And turning, repositioning, nutrition or hydration interventions, and applications of dressings and ointments, but not to the foot. And again, you can see these are all check off items in section M of your MDS. Moving on to non-pressure chronic ulcers of the lower limbs. Pressure ulcers are fairly straightforward and easy for you to code. Generally, you're going to have a assessment, skin assessment, and that will tell you the stage, the site. The orders will sometimes include that or should include that. It's pretty easy when you're reviewing the documentation to assign a code for your pressure ulcers. Where things get a little bit murky are the non-pressure chronic ulcers. So your diabetic wounds, your venous stasis ulcers. These ones are a little bit different because we don't code those by stage. We code those by site and severity level. And a lot of the times the nursing assessments don't give us that information. It'll ask for the size of the wound, and then the rest of it, if you're not a clinician, is kind of open to interpretation. You're like, I'm not really sure what they're trying to say here. So if you, as you can see here, for instance, for L97 non-pressure chronic ulcers of the lower limbs, the fourth character of that code will tell you the site. The fifth character specifies the laterality, and the sixth character is a severity. And you can see it includes breakdown of skin, fat layer exposed, necrosis of muscle, bone. It goes all the way down. You even have other specified severity. One of the things that I like to recommend is to form a partnership with your treatment nurses so that when they are documenting on non-pressure chronic ulcers, that they are documenting the severity level, even if it's in a narrative on the assessment. And that makes everybody's life a lot easier. If not, we do have a licensed nurse query for these type of ulcers, and that is included in your packet, which you will be receiving. And these are just more of the same. So you have to have documentation for each diagnosis, right? We always have to have supporting documentation. So if you're going to code it, you have to have some sort of documentation. Now, if the licensed nurse is getting treatment order that includes the correct condition, the site, the severity, or what sort of ulcer it is, that's sufficient if your physician is signing it. But you want to make sure that you've got good documentation to back that up. So the non-pressure chronic ulcers, again, everything I was saying before, we're talking about severity levels. And if you're going to be going the query route with your nurses, you want to make sure that they're signing them, just like a physician query tool, signing them and putting them in the medical record as supporting documentation. Now, this can get old if you have a lot of them and they have to sign one for each one. That's why I was recommending that you speak with your, pardon, your treatment nurses, and you form some sort of partnership and talk about the documentation, so that if you can find that documentation easily and quickly, you don't need to be going after them with a query tool. But this is what the query tool looks like. So at the top of the page, this is the top half. It's broken into 2 slides here. You put the resident's information, the date of the query, and then you would just put what, for instance, if they had a diabetic wound on the, or ulcer on their right calf, next to the word calf, I would type right diabetic ulcer, and then I would hand that over to the nurse. And on the bottom of the page, this is what it looks like. The nurse could check off the most severe severity level. So, you know, if they're telling you that they have necrosis of muscle and bone, you would code the more severe, which is necrosis of bone. Have them sign it, place that in the medical record as your supporting documentation. We have some new for 2022 codes for irritant contact dermatitis. These are a whole new character, whole new section, all new codes. So for instance, L24.A codes are for irritant contact dermatitis due to friction or contact with body fluids. And there's an excludes one note saying This does not include irritant contact dermatitis related to a stoma or a fistula. Those codes are L24.B codes. And you can see these are broken down by the type of body fluid. The first one is for unspecified body fluids, but then you've got saliva, then you have fecal, urinary, or dual incontinence, etc. So you want to make sure that you're using the most specific one related to how the physician is documenting. And then these are the ones, L24.B codes have to do with irritant contact dermatitis related to a stoma or a fistula. And those are broken down by the type. So the first one, point B0, is for not otherwise specified fistula if they're not specifying. Then we have point B1, which is related to digestive stoma. So, and then it's broken down further to give you more information that includes the G-tube, jejunoscopy, or related to saliva or spit fistula. And point 2 is for respiratory stomas, so that's for trachs. And point B3 is fecal or urinary stoma, so colostomies, etc. Moving along, we're going to move into diseases of the musculoskeletal system and connective tissue. These are your M codes. Immune disorders. So some immune disorders will garner one NTA comorbidity point on your MDS, and those are I-8000 codes. So when we're thinking I-8000 codes for NTAs, that means it has to map into NTA comorbidities. So that same tool that we went over, the clinical category tool, there's different tabs at the bottom. There's a tab at the bottom for NTA comorbidities. There's a tab at the bottom for SLP comorbidities. You would click on NTA and you would search for the code that applies to the diagnoses to see if that will get you a point. Now, that being said, most of the electronic health record software out there will tell you if something is an NTA or SLP comorbidity. Some of them will even tell you the number of points. So it really just depends on what system you're working with. But if you wanted to look that up on the tool, the map tool, then you could do that as well. Osteoarthritis, M15 to M19 codes. So when you say osteoarthritis, these codes, everything that falls within this category includes multiple terms: arthritis, osteoarthritis, DJD, so any of those. Now, if we don't know the site that we're dealing with, if the physician just specifies OA, osteoarthritis, or arthritis, or DJD, your default code will be M19.90, unspecified osteoarthritis, unspecified site. However, look closely at the documentation. A lot of times, if you go a little bit further in, you'll see they'll tell you maybe they've got osteoarthritis of both hips, or both knees, or one hip, or one knee, whatever it is. There are codes that are specific to the site and the laterality. So just pay attention to that. If they only have osteoarthritis of the left hip, then just code it to the left hip. M15 is polyosteoarthritis. So if they have arthritis of multiple sites, go ahead and use the M15 code for polyosteoarthritis. The only exception to that is if they have bilateral involvement of a single joint, don't code polyosteoarthritis. So if they have bilateral osteoarthritis of both knees, then just code bilateral osteoarthritis of both knees. Don't use the M15 code. And you can see broken down by category, you've got by site. M16 is for hips, M17 for knees, M18 is for first carpometacarpal, and M19 is other and unspecified osteoarthritis. So lupus, basically, and other inflammatory spondylopathies is the next category that can get you 1 point. Again, these are I-8000 codes. So the way you can look those up is marked here on the screen. As you can see, for lupus, you start with the main term lupus, subterm erythematous, subterm systemic, and that brings you to M32 codes. And then inflammatory spondylopathies, you just start with spondylopathy and inflammatory, and it takes you to an M46 code. Systemic sclerosis or scleroderma or crest syndrome will also get you 1 point. That is a chronic hardening and tightening of the skin and connective tissue. And those are fairly easy to look up. Just sclerosis systemic gets you to M34. We're going to move on to pathologic fractures. So this, you may notice, this is an M code. Pathologic fractures are M codes. So totally different chapter than your traumatic fractures. There's a lot of different terms that you can use for pathologic fractures, and we have a sampling here. Stress fracture, a chronic fracture, compression fracture, non-traumatic. Maybe they're saying it's due to some other disease. Maybe they've had cancer and it's spread to their bones, neoplastic disease. It just depends. So you have to be careful and think outside of the norm. It may not always be documented as a pathologic fracture. You may see one of these other terms. So keep your eyes open for that. If your resident has a pathologic fracture and we've done surgery for it, you don't have to code an aftercare Z code. You still just code pathologic fracture with the appropriate encounter code. So there's 3 different categories for pathologic fractures. You could have a pathologic fracture due to neoplastic disease. So they've got some sort of cancer that's spread to the bones, due to osteoporosis, or due to some other specified diagnoses. When it comes to osteoporosis, when you think about osteoporosis, that's systemic, right? It affects all the bones in the body. So therefore, it's not a component for codes under that category M81, osteoporosis without current pathologic fracture. So you've got 2 different types of osteoporosis codes. Either they have osteoporosis, they don't have a current pathologic fracture, or they do have a current one. And if they do happen to have a current pathologic fracture, you would identify the site of the fracture. So let's talk about somebody who has osteoporosis who has a fracture, because sometimes that can be really confusing. The guidelines say that codes from category M80, osteoporosis with the current pathologic fracture, should be used for any patient with known osteoporosis who suffers a fracture, even if they had a minor fall or trauma, if a fall or trauma of that level would not usually break a normal healthy bone. That being said, it's still up to the provider, the physician or physician extender, to designate whether it's traumatic or non-traumatic. It's not appropriate for us as a coder to interpret that. So if they mention osteoporosis in the same breath as the fracture, then I'm going to say, okay, they're telling me it's an osteoporotic fracture. But if they're not, if they're saying, you know, they're really harping on the traumatic aspect of it, then I'm not going to code it as such. If I'm not sure, I will query the physician. And that's the beauty of a query, is we can always ask them and have them document it to be more clear so that we know how we need to code it. And then of course, osteoporosis without fracture, it's M81 code. Osteomyelitis, these are M86 codes. So that's an infection of the bone, has 2 NTA points. And again, these are I-8000 MDS codes. You can see here, we've broken down the character for what each character represents. The first 3 characters will be M86, that's a category representing osteomyelitis. The 4th character will tell us the type, and you can see there's a few. Acute hematogenous, other acute osteomyelitis, subacute, chronic, I mean, there's a bunch. Then the 5th character tells us the site, and the 6th character tells us the laterality. And because it is an infection of the bone, there is an instructional note telling us to use an additional code from category B95 to B97 to identify what's causing it, what the infectious organism is. Remember, we talked about infections yesterday. I was saying there's two types. There's combo codes like A4151, which is sepsis due to E. coli. And then we have N39.0, which is just urinary tract infection. And those standalone infection codes will always ask you for an additional code from category B95 to B97 to tell what the infectious organism is if we know it. So osteomyelitis is another infection code. It's not under the infection category, but it is an infection and it still follows the same rules. Here is a change to the clinical category for multi-system inflammatory syndrome, M3581. This one moved from non-surgical orthopedic musculoskeletal to medical management. So what's the rationale for that? Well, they did that because it's in the name, multi-system inflammatory syndrome. So it's multiple systems. It's not just the musculoskeletal system. So if it's going to affect multiple body systems, the idea is for the clinical category to be accurate. So that is why having it moved to medical management is more accurate. Here is a code change. Now, actually, if you look at the code, it's exactly the same. So it's a code descriptor that has changed. M35.00 is the code for Sika syndrome, but they've changed it to Sjogren syndrome. So all of the codes from category M35, they've changed the terminology to Sjogren syndrome. So you can see they've all been changed. And these are all the different body systems affected. So inflammatory arthritis with peripheral nervous system involvement, central nervous system involvement, and so on and so forth. And you can see they've all just changed from Sika syndrome to Sjogren syndrome. I think they do that sometimes when, maybe an old fashioned term just kind of falls out and they're going with a more current terminology. Low back pain. That code you can see has gone from 4 characters to 5 characters. Used to just be low back pain and that was it. And now we can break it down. So we've got M54.50 is for low back pain unspecified. That includes loin pain or not otherwise specified lumbago. And then M54.51 is vertebrogenic low back pain. And then we have other low back pain, 0.59. Okay, we're going to do our first exercise. So we have a resident who's admitted to the hospital following a fall with a diagnosis of osteoporosis pathologic fracture of the right hip, which was treated with ORIF. Patient has additional diagnoses of hypertension and stage 2 chronic kidney disease. And they're going to the SNF for PT and OT rehab. And you want to select all the codes that apply. So I'm going to give you a few minutes to look up some codes, and then I'm going to pull up the poll. I'll give you 5 minutes, and then I'll pull up the poll and you can select it. But meanwhile, take the time to use your code books and look these up. We have as our principal diagnoses M80.051D, age-related osteoporosis, with the current pathological fracture of the right femur, subsequent encounter. So right below it, the second bullet point, you can see how that code is looked up in your book. You start with the term osteoporosis, age-related with current pathologic fracture, and then pelvis. So remember, the doctor's documentation for this scenario was pretty clear that it was an osteoporotic fracture. Then we have a combo code for hypertensive chronic kidney disease with stage 1 through 4 CKD. This resident had hypertension and CKD stage 2. So that requires a combo code. And then that code tells you to code also the stage of the chronic kidney disease, N18.2. So you have to pay attention to what the instructional notes are asking of you. Moving on, we're going to move on to our next body system, which is the genitourinary system. These are your N codes. So let's talk about acute and chronic kidney failure. N17 is the code for acute chronic failure. Pay close attention to the documentation that you're getting from the hospital. A lot of times you'll have a resident who's admitted with acute kidney failure, but by the time they leave and come to you, that has resolved. So just be very, very careful with that, that you're not coding it if it's completely resolved and there's no monitoring going on, nothing else going on to indicate that they're still in acute kidney failure. Then we have chronic kidney disease, and those are your N18 codes. And there's an instructional note there telling you to code first any associated diabetic chronic kidney disease or hypertensive chronic kidney disease. In the scenario that we just completed, you will note that sequenced before the N18 code was your I12 code for your hypertensive chronic kidney disease. That is why those are sequenced the way they are, because it tells you to please code first the combo code. So that's why that hypertension combo code went first before the stage of the CKD. And then N19 is unspecified kidney failure. I don't see any reason why you would need to use that code. Usually your physicians document what type. Urinary tract infections, that N39.0 code, we've seen it before. That was yesterday, first day, we went over coding urinary tract infections. Remember, you need a secondary code for the causal organism if it's documented. But then you can see here, it breaks down by type. So we have N30.00 and N30.01 for acute cystitis with or without hematuria. So if your physician is documenting that it's cystitis, meaning it's confined to the bladder, great, code to that level of specificity. Most of the time, though, they're just going to tell you it's a UTI, and they're just going to leave it at that. And then we also have N34.2 urethritis, which it's impacting the urethra. All of these are all sort of UTI codes. Some of them are a little bit more specific, but all of them are standalone infection codes, and all of them are going to ask you to use an additional code from B95 through B97 to identify what the causal organism is. So just be aware of that. BPH, benign prostatic hyperplasia. Those have two different categories. There's subcategories for BPH, enlarged, and then also nodular. So if they have nodular, that's a little bit more specific. But both of those will ask you if they have lower urinary tract symptoms. And if you look at N40.1 in your book, it will tell you what some of those lower urinary tract symptoms are, like urinary urgency or frequency. There's a whole bunch of them. So if they have any of those, then you want to code it as BPH with lower urinary tract symptoms. Symptom signs and abnormal clinical and lab findings. These are R codes, R00 to R99. When it comes to coding symptoms, we don't usually code them. In particular, signs and symptoms that are routine to a particular disease. So if you have somebody who has CHF, they're going to have edema in their legs almost invariably. So we don't code that edema. We just would code the congestive heart failure. Same thing with shortness of breath with people who have COPD, fever with pneumonia, urinary urgency and UTI, etc. Pain with fracture, we don't code those. So when we're coding, we can code a symptom that is outside of the normal realm with a condition, or if all we have is symptoms, a list of symptoms and no definitive diagnoses, and we definitely don't have a definitive diagnosis, then we can code them. A lot of our therapy codes, like R26.2, I believe that's difficulty in walking. A lot of times therapy uses that as their treatment diagnoses, and that's fine. You can put those on the claim. Just make sure that when therapy's done, that you resolve those codes. Coding from labs and x-ray reports. We don't code from them, but what we use those for is to give us further specificity to a diagnosis. So for instance, if a physician documents that somebody has a fracture of their right femur, and that's all the information they're giving us, but we have a x-ray that says it's a right intertrochanteric femur fracture, we can then use that information within the x-ray to further define the physician's diagnosis of a femur fracture. So again, we can't just look at a x-ray report or a lab and go, oh, hey, look, and just start coding from that. We have to have the physician document the diagnoses first, but those are great tools to help us assign the best, most specific codes when we are coding. When it comes to nursing special care high in PDPM, if you have a resident who has fever and pneumonia, vomiting, weight loss, or feeding tube, you can see these are all different sections on the MDS that will impact our nursing category special care high. There's a little bit of information here about tube feeding classification requirements. I'm not going to bore you with that. But do remember, if a fever is a symptom that is associated routinely with the disease process, then do not code that separately. Respiratory arrest is 1 NTA point, and that is an I-8000 code, and it is an R code. Comatose or coma, again, this will impact our nursing special care high category. And what you want to be aware of is if we have somebody who is comatose, we want to make sure that our section GG items of the MDS reflect that they show that the person is completely dependent or activity did not occur. We don't want to document that they're running down the hallway if they are in a coma. So just be careful with that. Make sure that we always have good supporting documentation and that our section GG reflects that as well. Falls. So there's a couple different codes you can use for falls. R29.6 is repeated falls, and we tend to use that for somebody who had a fall in the present, maybe that caused a fracture, versus Z9181 history of falls, somebody who's fallen in the past and they're at risk for future falls. And you can use both together if it's applicable to the particular resident. Therapy medical diagnoses. It should be the same or must be the same as the listed principal diagnoses on the chart for PDPM. So you want to make sure that the codes that you're using is for something that is medically necessary, appropriate, and relate to the therapy discipline specific service. And you want to make sure that your therapy evals have that they're clearly delineated as to what is a medical diagnosis and what is a treatment diagnosis. So a lot of times you'll have a fracture, you'll have a fracture code, and that will be your medical diagnoses, but then you have difficulty in walking, which is an R code, as a treatment diagnoses. You want to make sure that your therapy clarification order includes the therapy treatment diagnoses, the code for that, the R26.2 or M6281 or any of the other therapy codes that you would use, and they should be resident specific. That's one of the things that CMS harps on, right? Is having the exact same therapy treatment diagnoses for every single resident. It shouldn't be that way. And again, the two I mentioned are R26.2 for difficulty walking and M6281 for muscle weakness. For those who have respiratory therapy, if you have a subacute, that can impact your nursing special care high. And that is a checkbox in section O on your MDS for respiratory therapy for all 7 days. And for coding purposes, you would code the reason why they're getting respiratory therapy. COPD or respiratory failure, whatever that is. Make sure that that is also coded on your claim. Coding updates for 2022, meaning these are already active. Remember, all code updates are effective in October. Sometimes they'll do some mid ones in April. And when the pandemic started, by April, they had given us the code for COVID. So we do have some updated codes coming this April related to the immunizations for COVID. And we'll get to that later when we get to that section. But you'll notice they're usually, your main ones will be October, and then sometimes they throw some in April. So cough, R05 cough is no longer an active code. It's no longer 3 characters. It's now 4 characters, and it's broken into types. So you've got 0.1 for acute cough, 0.2 for subacute cough, and 0.3 for chronic cough. Oh, and there's more. 0.4 for cough syncope, and there's an instructional note to code for syncope and collapse. That must be one heck of a cough if it makes you pass out. And then you've got other specified and unspecified. And there's some excludes notes there that you can take a look at. We now have a new code category, R45.88, non-suicidal self-harm. So that includes self-injury, self-mutilation, any sort of self-inflicted injury without suicidal intent. So maybe somebody who cuts, that sort of thing. And then there is an instructional note telling you to code the injury as well. Feeding difficulties has been expanded from 4 characters to 5. We always talk about code expansion. We were talking about that placeholder X yesterday and why they use that. Codes can be expanded. You know, you have these little 3 and 4 character codes, and now we're able to expand it as time goes on and give us more specificity. So you can see here, R63.30 is for unspecified feeding difficulties, and then R63.39 would be other feeding difficulties. Injuries and poisonings. This is the single largest category in your book. You'll notice it's a big fat section in your book. A lot of codes here. Traumatic injury codes will be found within this chapter. You want to code to the specificity that your physician is giving you. And sometimes you have to look at the X-ray reports, the surgical reports to get the best information. So just make sure that you're aware that you're looking at everything that could lead you to the correct code. You don't want to just copy a code from the acute care documentation. One, you want to verify that it's an active diagnosis, but also if they had a fracture, when they go to the hospital, the code that's assigned by the hospital will end in a letter A for active care. That's when they're maybe doing surgery or maybe they're putting a cast, whatever it is. So you want to be careful that you're using the correct 7th character. The other thing you want to be aware of when it comes to injuries is these have 7th character. These are all 7 character codes. So you want to make sure that you're using the correct 7th character that's appropriate for long-term care. They're all going to map. So you have here a sample on the screen for somebody who has a fracture of the right clavicle. And you could see A, B, D, it doesn't matter. I'm just telling you, they're all going to map. It might not follow the coding guidelines, and you might have a false sense of security if you feel that, well, if it maps, it's good, right? Not necessarily. You have to use a little bit of critical thinking in this case. So just be careful that you're using the correct 7th character to the documentation and to what applies for long-term care. Traumatic brain injuries is a speech and language pathology comorbidity category. So for traumatic brain injuries section, there's a checkbox I-5500 on your MDS that would need to be checked off. But for your coding purposes for your diagnoses list, that would be a code from category S06 should also be on your diagnoses list. And then if they had a traumatic brain injury in the past and it's healed, but they have some sort of residual or sequela, then make sure you're coding it as a sequela code. And that your injury code has an S on the end for sequela. Fracture coding defaults. If your physician doesn't document that a fracture is displaced or non-displaced, you will assume or default as a displaced code. And if they don't designate whether a fracture is open or closed, code it as a closed fracture. An open fracture would be a fracture where the bone comes through the skin, also known as a compound fracture. You want to just be aware that for those, there are additional and different 7th character encounter codes. So somebody who has a fracture of the forearm, the femur, or the lower leg, including the ankle, you are going to need to know something called the Gustio open fracture classification. That should be documented if they had an open fracture within the surgical report. And these are what some of those encounter codes for fractures look like. A is for initial encounter, active treatment, that would be the hospital. D is for subsequent encounter, routine healing, that's generally the one you're going to use. But then we have some other ones here for subsequent encounter, delayed healing, or non-union or malunion. All of those, if you're going to use those are meaning there's some sort of complication with the healing, you must have documentation that that is the case. And then S is for sequela. So if somebody has an injury and as a result they've got a late effect, you would code the late effect first and then the injury itself with the letter S at the end for sequela. And that was what I was just saying. So you want to code sequela codes after the acute injury has healed, and code the injury that precipitated the sequela and the code for the sequela itself. And here is a example of that. If you have somebody who has fractured their first cervical vertebra, so they fractured right here in their neck, and as a result they are now quadriplegic, you would code the quadriplegia first, followed by the injury code with a letter S for sequela. So you want to be really, really careful with using that letter S. It should be judiciously used and rarely used. It's pretty rare. Anytime I see a fracture code with an S for sequela, I'm going to yank that chart and start looking because it's fairly rare. Shouldn't be seeing that often. So be careful about that. And remember, the injury code would never be the principal diagnosis in a sequela situation. You always code that sequela or late effect first. Amputations. 2 different types of amputation codes. There's, more than one way that it can occur. If somebody has an accident and in the course of that accident, an amputation occurs, that is a traumatic amputation. And those codes begin with S, meaning they're from this injury chapter. So you would look that up by the term amputation. But then there's the more common, and at least in long-term care, and that is for an acquired amputation, a surgical amputation. So that's usually somebody who has maybe diabetes, they've got gangrene, pardon, and so they have to go in and surgically amputate. That's different, and you look those up different. So an acquired amputation, again, a surgical amputation, which is the most common scenario. This is how you would look it up in a book. You would look up the term aftercare and then following surgery for amputation, and you get Z4781. When you go to code Z4781, there will be a clear instructional note in red telling you to code also the limb that was amputated. So it'll tell you, look up a code from category Z89 for what limb was amputated. And that would be your second code. And amputations not identified as partial or complete, you're going to code them as complete. That's your default. And this is for traumatic amputations. You start up the word amputation, then traumatic, and then you look up the site. So the example here is somebody who was in a car accident and they have a traumatic amputation to their right upper arm at the elbow. And you can see that's an S code. Burns versus corrosions. Those are nursing category impacted, clinically complex, and also an NTA comorbidity. When it comes to the NTA, though, only 3rd-degree burns or corrosions will map you into the into that category for NTA. What's the difference between a burn and a corrosion? A burn is a heat source. So heat, electricity, radiation, fire, and corrosion is a chemical burn. So when it comes to coding burns and corrosions, you want to make sure that you're assigning 2 codes. One code for the classification. So is it a 1st degree, a 2nd degree, a 3rd degree? That's the first code. Then the second code is the percentage of body surface that was impacted. So, you know, when you used to watch old TV shows and they'd say, oh, they had, you know, 3rd degree burns over 20% of their body. That's 2 codes, one for the 3rd degree and one for the 20%. So you want to use a separate code for each burn site and make sure that you're not coding unspecified. That doesn't look good. You know, we want to show that we know what we're treating. T14.91 codes are for suicide attempts. And we have 7th character A for initial encounter, D for subsequent, and S for sequela. You would use the sequela one, you know, maybe they attempted suicide and now they're in a coma. You would code the coma first. Then you would use T14.91XS. So a little bit back, remember we had that non-suicidal intent self-injury codes. In the past, we didn't have that. It was just suicide attempt or nothing. So now we have a little bit of a delineation between the two, which is more specific, so that's much better. Poisoning, adverse effects, and underdosing. Yesterday, we talked about the table of drugs and chemicals. And that table, if you remember, has the name of the drug or chemical going vertically down the page in 2 columns, and going horizontally across the top would be poisoning, adverse effect, and underdosing, along with the intent, right? Whether it's poisoning assault, poisoning accidental, poisoning the intent of self-harm. Adverse effect. So when you think of poisoning, that would be somebody who has taken an overdose of a substance, whether accidentally or not. The wrong substance was given or taken in error, or maybe the wrong dosage. Maybe we thought the doctor said 200 milligrams and they really said 20 milligrams. That's a poisoning. And then we have adverse effect, and that is probably your most common one that you're going to encounter. That's somebody who has some sort of sensitivity reaction to a medication that was correctly prescribed, correctly administered. Your body just happened to have a bad effect to it. I don't know about you, but you know, there's certain antibiotics, when I take it, you know, about 20 minutes after taking it, hives all over, the itching. So how would you code an adverse effect? You would code the reaction first, followed by the medication name, the code that corresponds to that medication, and adverse effect. So you want to make sure that you're sequencing those correctly. And then underdosing would be taking less of a medication that is prescribed or instructed, either inadvertently or deliberately. So when it comes to poisoning, and again, it could be an overdose, wrong substance, wrong route of administration, whatever it is that falls under the category. And these codes are from T36 to T50. And the 5th or 6th character will depend on the intent, whether it's accidental, intentional, assault, or undetermined. So I've had people say, what would assault be? That would be somebody giving somebody a medication with the intent of harming them. Somebody else gives it to somebody. You didn't take it yourself. And then 4 would be undetermined, and sometimes we don't know. Again, adverse effect, correctly prescribed, properly administered. The 5th or 6th character will be a number 5. And then these are some examples of adverse effects: rash, tachycardia, delirium, vomiting, respiratory failure. So just remember that's your most common. And then underdosing, you can't use the underdosing codes as a principal diagnosis ever. But if they have an exacerbation or a relapse of their medical condition for which they were taking that medication that they were underdosing on, make sure you're also coding that condition too. And then there's some non-compliance codes, Z91 codes, and those can be used to indicate intent if known. And here's some examples of non-compliance codes: non-compliance with dietary regimen, non-compliance with renal dialysis, or with other medical treatment and regimen. Now, a little word of caution about these non-compliance codes. You want to make sure that you're not just coding them, if nursing is documenting, you know what, they aren't wanting to eat their food, they're living on ding dongs and Coca-Cola and they're diabetic. We can't just look at that nursing documentation and assign that Z9111 code. The physician would have to document it. That being said, it's important that we communicate with our physicians so they know what's going on with our residents. But just be aware, these would be physician documented for us to use these codes. Complications of grafts. So anytime you have some sort of device or graft that causes complications, we have to make sure that we have physician documentation. And you're probably getting tired of me hearing that, but we do. There has to be some sort of physician documentation that shows that a complication is caused by that device or that graft. So it could be a urinary tract infection due to a Foley catheter. If they have a Foley catheter and they have a UTI, these are two separate things. But if your physician says this infection is due to this Foley catheter, you can put the two together and you can use a complication code. Without that documentation, we cannot do that. Now, it's probably obvious that the Foley catheter is causing the UTI, but without that documentation, we cannot use those complication codes. So just be really careful about that. And how you look up these complication codes, lovely. You start with the word complication, easy enough. Then you look up the device. It could be urinary, it could be a catheter, it could be whatever. Then you look up whatever the complication is: infection, inflammation, etc., whatever it happens to be. Here is an example. We have infection due to internal joint prosthesis. So you start with the word complication, then joint prosthesis, internal infection, and then the site, and that takes you to a T84.5 code. And then infection due to a Foley catheter, it's also a complication, catheter, urethral, and then infection to take you to T83.511 code. And this one, if it's an infection, remember, any infection code is going to either be a combo code where it tells you what the causal organism is, or it's going to ask you to use an additional code to identify the infection. And these complication infection codes are no different. They're going to ask you for the same. Traumatic brain compression and herniation. We have some changes to the codes. It used to be S06.890, other specified intracranial injury. And now they've changed the category to S06.A for traumatic brain compression and herniation, which includes traumatic cerebral compression. And they're asking you to code first any underlying traumatic brain injury. And there's a whole list here of ones to choose from. And then they've added S06.80, traumatic brain compression without herniation. And then traumatic brain compression with herniation. And again, with those, you want to code first your underlying traumatic brain injury. We have some changes to poisoning, adverse effects, and underdosing of cannabis. So they've gotten rid of T40.7X, and they've replaced that X with a 1 or a 2. So T40.71 is for poisoning, adverse effects, or underdosing of cannabis. And then T40.72, poisoning, adverse effects, and underdosing of synthetic cannabinoids. So those are now broken down into the 2. Here is our next scenario. We have a resident is admitted to long-term care facility following an acute hospital treatment of a displaced traumatic fracture of the base of the neck of the right femur in order to heal the fracture and regain strength. So I think we'll start with 5 minutes and see where we're at. The principal diagnosis is S72.041D, displaced fracture of the base of the neck of the right femur, subsequent encounter for a closed fracture with routine healing. Why did we use this code? We use this code because they have a fracture and have gone to the hospital first. Now they're coming to us. The issue with this one that we want to be careful with is that we understand that this is not active treatment. So that's why we're using that letter D. And we don't want to assign an aftercare Z code because the coding guidelines tell us not to do that. So some of us had selected the orthopedic aftercare code and the fracture code, and this is really common. I believe that the reason why so many times we want to use the orthopedic aftercare code and the fracture code goes back to when we used to code in ICD-9. In ICD-9, we would use a code for a separate code for the surgical aftercare. And we don't have to do that anymore with ICD-10. With ICD-10, I want you to think of that injury code as being the correct code and that letter D for subsequent encounter to represent the aftercare. So it's sort of like two codes in one. So pay attention to that and just remember, aftercare codes and fracture codes do not mix. You cannot mix them together. None of the fracture codes, not the not the acute and the traumatic, and not the I can't think of the word right now. The other ones, the M codes. Sorry, the osteoporosis fractures, etc. We still don't want to use aftercare codes with any of those, the non-traumatic ones. Okay, we're going to move on to diseases of unknown origin. These are codes that start with U, which we have never had until, lucky us, to live in the time of a pandemic. We now have U codes for that. So at the same time they gave us the one for COVID, they also gave us this vaping related disorder, which is also relatively new. And one of the things that they've done with vaping related disorder is they've changed the clinical category. The clinical category used to be return to provider, and now they've moved it to pulmonary. And they did that because a lot of the times people who have vaping disorder, they need a lot of treatment. They need oxygen, steroids, etc. So those things can carry over into long-term care settings. And in that case, that's why they changed it. So again, they want a more accurate clinical category assignment. I don't know about you, I have not yet seen this code used in any of my facilities, but it exists nonetheless. And then we have U07.1 for COVID-19. And if they have pneumonia due to COVID-19, you also want to use J12.82, pneumonia due to COVID. And you can see there's excludes notes for coronavirus as cause of disease classified elsewhere, B97.2, coronavirus infection unspecified, and pneumonia due to SARS-associated coronavirus, J1281. All of these three codes that you see refer to other coronaviruses, not COVID-19. COVID-19 is a new, different sort of coronavirus, so you don't want to mix those up together. If they happen to have another coronavirus in conjunction with COVID-19, you could then use any of these three codes. That's why it's an excludes 2. So when it comes to coding COVID-19, if it meets the definition of a principal diagnosis, code it as the principal diagnosis, and then you can use additional codes for any associated manifestations. And for those who have pneumonia due to COVID, code COVID first, the underlying cause, then J1282. And once time has passed, they have a history of COVID-19, you want to assign code Z86.16, personal history of COVID-19. We have a new code for 2022, U09.9 for post-COVID-19 condition. So this is to establish a link between COVID-19 and some sort of post-COVID-19 sequela. If they have respiratory failure or something along those lines due to COVID, you would code whatever the condition is, followed by this U09.9 code. So again, code first the specific condition. Here's some examples: chronic respiratory failure, loss of smell, loss of taste, multi-system inflammatory syndrome, pulmonary embolisms, and pulmonary fibrosis. We do know that pulmonary emboli is one of those things that seems to come along for some people with COVID. So code first the condition, then that post-COVID condition code. And let's take a look at how these map to clinical categories. U07.1 COVID-19 maps to pulmonary. Post-COVID condition does not. It's a return to provider code. Now, we don't want to stress about that because, remember, what are we doing with that code? We are first coding the condition. So if they have chronic respiratory failure as a result of COVID, chronic respiratory failure is going to map. Now, if they have loss of smell, loss of taste, well, you know, I don't want to say no big deal because that's horrible. But as far as Medicare is concerned, that's not a reason for skilled care. And then the other ones that we've been using, encounter for screening, and then the symptom codes, cough, shortness of breath, etc. Those are all return to provider codes. Remember, I was telling you earlier, we have some new codes, but these ones aren't available for use until April 1. So we now have some codes for vaccination status for our residents. So Z28.310 unvaccinated for COVID-19. Then we have Z28.311 partially vaccinated and Z28.39 under immunized status. So we don't want to use these codes for people who are not eligible for the vaccines. If their physician is saying they are not a good candidate for these vaccines, you don't want to use these codes. You don't want to code somebody with under immunized code if their physician says they can't have it. So just be careful with that. And Z2839 and other immunized status includes delinquent immunized status or lapsed immunized schedule status. So maybe they had the first dose and they didn't go back for the second one. So here's some criteria for that. That under immunization status code can be used when the resident has had one dose of the COVID-19 vaccine, has not received at least one dose, I should say. And then partially vaccinated may be assigned when they've gotten one dose, but they haven't received the full set of doses. So remember, we can't use those until April 1. That's when you would start using those. And obviously, you're not going to sequence those in your top 10. Those will be, you know, further down your diagnoses list, further down the list for statistical reasons. We want those on there. And then Z codes, factors influencing health status and contact with health service are your Z codes. So very few Z codes are appropriate as a principal diagnosis. Your Z47 Z codes, your Z48 will map, and some Z43 codes will map. Hospice coding. For residents who have hospice, Z51.5 palliative care, encounter for palliative care, would be a secondary code. Remember, the reason for the hospice would be the principal diagnosis, whatever that may be. We have a couple of different other types of Z codes. We have the aftercare Z codes. Those ones map to a clinical category. Those you can use as a principal diagnosis. But we also have history and status Z codes. So history codes are informative, and that would be like history of falls or history of a CVA. But then you have status codes, and those are informative and sometimes required. So for example, we have an example here, Z96.6 codes that start with Z96.6 are presence of an orthopedic joint implant, So if you have somebody who had a right hip replacement, your principal diagnoses would be Z47.1, aftercare following surgery for joint replacement. But we have a lot of different joints in the body. The payer wants to know which joint was replaced. So that is why there is an instructional note saying, hey, tell us what joint is replaced, and use a code from category Z96.6. And then also somebody who had a surgical amputation, we want to know what limb was removed. So that's why Z89 code for acquired absence of limb would be a secondary code that would be required in that scenario. And just remember, history and status Z codes can never be your principal diagnoses, but they are important codes, in particular the two I just mentioned about the orthopedic joint implants and then the acquired absence of a limb code. We need that information in order to further define the claim and make it clear to the payer what was done. The coding guidelines state aftercare Z codes are generally first listed to explain the specific reason for the encounter. So this is for somebody who requires continued care, maybe after a surgery. We use these fairly often. Orthopedic aftercare codes are not used for aftercare of injuries, like a fracture, but they are used for following surgery for a chronic condition. So just remember, if it's an injury, it's some sort of fracture, you will never use an aftercare code with it. So just be very careful about that. If you have an injury, like a fracture, whether it's a pathologic fracture or a traumatic fracture, you want to assign the appropriate code for the fracture itself. No aftercare codes. Now, for joint replacements, again, for partial or total joint replacements due to a chronic condition, you would use Z47.1, aftercare following joint replacement, followed by a code showing which joint was replaced. For revisions, you would still use the Z47.1 code. If you have a resident who, this happens sometimes where somebody has a femur fracture and it's way high up on the hip, it's way up there. And so how they treat that is they do a hip replacement. But remember, the primary thing that happened here is they have a fracture. Fracture will always be coded if it occurred. You always want to code the fracture. That will be your primary. So you code the fracture, but they also did a joint replacement. So you run into a bit of a conundrum. I want to code the fracture, but I also want to code the fact that they had a joint replacement. But if I do that, if I use a orthopedic aftercare code in conjunction with a fracture code, I've just violated my coding guidelines, and that's a problem. We don't want to do that. So how can we code for a scenario like that? Well, code the fracture code and then use an additional code to identify what joint was replaced. So just always keep that in mind, that when we treat a fracture with a joint replacement, we code the fracture and then we identify what joint was replaced. We do not use an orthopedic aftercare code. Z47.3 is for aftercare following explantation of a joint prosthesis. That's where they have to surgically remove and reinsert an artificial joint prosthesis. Let's see if the surgery didn't go well and maybe they have an infection or inflammation, or they've got pain in that artificial joint and they need to replace it. And it is a staged procedure. So this code includes all stages. That includes the removal and the reinsertion of the artificial joint prosthesis. And there are some secondary codes for absence of the joints, right? Shoulder, knee, or hip joint. If they've taken out the joint, but there's an infection at the site and they're going to treat it, you're not going to use that explantation code. What you're going to do is you're going to code it as a complication because there's an active infection going on. So you would look that up with the term complication, then joint prosthesis, then internal, and then whatever that complication is, infection, etc. So you would use the letter A for active treatment if they're still getting antibiotics for that complication. And then, of course, we have other orthopedic aftercare codes following surgical amputation, following scoliosis surgery. And Z4789 is aftercare for orthopedic surgery aftercare codes. You're going to use that again for chronic conditions. You know, if they had a spinal fusion or a laminectomy, but as long as there's no traumatic injury going on, it would be a chronic condition. Z48.3 is aftercare following surgery for neoplasm. And this code will also ask you to use an additional code to identify the neoplasm. So pay close attention. Sometimes when we're looking through documentation, we're like, oh, what's the body system they had surgery on? And we want to assign that body system code right away. So for instance, there was a claim that had at one of the facilities I was at where I was reviewing their Medicare charts, and I saw one that had aftercare following surgery on the digestive system as the principal diagnoses. And then the secondary code was a code for colon cancer. And then that kind of, you know, got me thinking, this might not be the correct principal diagnoses. But then I went and I looked at the orders, and there was, sure enough, you know, surgical site. And then I was reading the documentation, and they had removed a neoplasm. They had removed a tumor from the colon, and it was colon cancer. So while they were on the right path, thinking, what's the body system? It's the colon, it's the digestive system. The more specific correct answer would be this aftercare following surgery for neoplasm code. That would have been the best code. Then the secondary code for what the neoplasm was. And that would have been that would have been the better way to do it, the more correct way. And here are those body system codes. There's Z41.81. They are 6 characters. So the 6th character will tell you what body system. And just to be aware, if they had surgery on the eyes or the ears, that would be aftercare following surgery on the sense organs. You won't find a separate one for eyes and ears. For residents with surgical wounds, that impacts your nursing category for extensive services. That would need to be checked off on category M1040E on your MDS. And there isn't a separate code per se for that. If they have a fracture code or injury code or an aftercare code, that's included. That would cover this. Artificial openings. These are pretty common. You have 2 different categories of codes for artificial openings. You have codes that start with Z43, attention to artificial openings. So for instance, Z43.1 is encounter for attention to gastrostomy, but then there's a corresponding Z93 code. So Z93.1 would be gastrostomy status. You want to use the Z43 codes. And the reason you want to use the Z43 codes instead of the Z93 codes is Z93 codes are just status codes. Z43 codes reflect the care that we are providing to the artificial opening to keep it clean, infection-free, patent, all the things that nursing has to do to make sure that everything goes well with that artificial opening is represented in the Z43 codes. Those are the ones you want to use. Bowel and bladder appliances or ostomies will impact your NTA comorbidity or your SLP, depending on which one we're talking about. And your nursing extensive services category if they have a trach. And again, you want to use your supporting Z43 codes on your diagnoses list. For residents with a feeding tube, and the definition of that in the REI manual is a presence of any type of tube that can deliver food or nutrition, fluids, etc., meds directly into the GI system. So that can impact your nursing category. If they have fever in a feeding tube, that's special care high. If it's just a feeding tube, no fever, that is special care low. And there's some information here about feeding tube classifications. I'm not going to get into that. I'm not a nurse. It doesn't make much sense to me, but for you MDS nurses, this all makes perfect sense and you know which one to select. but you're going to code the reason for why that resident has the feeding tube, if it's dysphagia, whatever, plus the Z43.1 code. Major organ transplant status. So for residents who have had a organ transplant status, that will get you 2 or 3 NTA points, depending on what organ was replaced. So the lung is 3 points, all other major organs 2 points. So what you want to look for as far as supporting documentation is, 1, documentation that they had a transplant, and that would be coded under a Z93 code. And then you're going to look for anti-rejection medications. All very important. For residents who are on a ventilator, ventilator or respirator, if they're dependent upon those, that will impact your nursing extensive services category. And remember, yesterday we were talking about the nursing category. It's hierarchical. So depending on what diagnoses they have, that will map the resident into the appropriate nursing category. It's sort of automatic depending on how you answer your questions. And then it is 4 points on your NTA, 4 NTA points. It's a checkbox on section O of your MDS. And if they are on a respirator, you need to code on your diagnoses list Z9911 dependence on respirator. Pardon me. For those residents on dialysis, and per the RAI manual, this is peritoneal or renal dialysis. So if they're doing peritoneal dialysis at your facility, that would count. Or if they're going out for renal dialysis at a DaVita or some other center, then that would also apply. It impacts your nursing special care low category, and it needs to be checked off on section O on your MDS, and you need to make sure that you're using code Z99.2 dependence on renal dialysis. And when somebody has renal dialysis and we're talking about chronic kidney disease, you would use N18.6, end stage renal disease. Oxygen therapy will impact your nursing category, clinically complex. It's a checkbox on section O of your MDS. And you also want to code Z99.81, dependence on supplemental oxygen. And for residents with cancer who are getting chemotherapy, this will impact your nursing category. It's a section O on your MDS, and you want to code the reason for the chemo, whatever the cancer is, etc. And the same thing goes for radiation. For those who are getting IV medications, that's a checkbox on your MDS in section O, and you want to code the diagnoses for the use of IV meds. If they have pneumonia and they're getting an IV medication, you would use the code for the pneumonia, and then on the MDS, this checkbox on section O would be checked off. Transfusions can impact your nursing category, and that's also a checkbox on section O of the MDS. You're going to code the reason for the transfusion, and we do not include transfusions that were administered while the resident was at dialysis or chemotherapy. So just be aware of that requirement. And I think this is, I don't know, the 20th time I've mentioned this, but aftercare Z codes should not be used for aftercare for conditions such as injuries, including fractures, where 7th characters are provided to identify subsequent care. So we're going to talk about something that is popping up more as far as coding, and this is the social determinants of health. This is brand new as far as us introducing this within our materials, and these are different things, unmet social needs that can negatively impact somebody's health. So if somebody doesn't have enough food to eat, or they have poor quality food, they can end up with diabetes, hypertension, heart failure, all kinds of problems. If you don't have a house, if you don't have a place to live, then, you know, you're not going to be worrying about keeping yourself healthy. You're going to be worried more about a roof over your head. And if you don't have transportation, you're not going to be able to make it to, you know, doctor's appointments, pharmacy, etc. So that leads to lower compliance with your healthcare. So these are all things, these are all socioeconomic factors that impact your total health. You can see there's a little diagram off to the right, and they're saying that socioeconomic factors make up 40% of your health. 40%, that's a lot. Just below that would be your health behavior, whether you use tobacco, you know, your diet, your exercise, alcohol or drug consumption, sexual activity. Those all also contribute, but are actually less than your socioeconomic factors. So very, very important. And they're now trying to collect that data, and that's up to us to code that. And we'll get into that in a minute. So now, if we have this information, if we have the information that we have a resident who is homeless, suffers from food insecurity, these are things that we can be coding. Now, again, they're Z codes, and they're not aftercare Z codes, so they wouldn't be sequenced first, but they would be low on your list of your diagnoses list, but we should be coding them. And we can get this information based on documentation from clinicians other than the physicians. So other people who are documenting it in the official medical record, social services, case managers, nurses, that sort of documentation we can code. And again, we can code social determinants of health for instance, if a resident self-reports these things, as long as that documentation is then incorporated into the medical record. So if you have a resident who says, I am homeless, I have no place to go, and they're telling the social services this during intake, social services can document that, and then we can take that information and we can incorporate it into our diagnoses list. And these are a few of the social determinants of health categories. You know, problems related to education, literacy, employment, physical environment, housing, etc. There's a whole lot of them. But the main one that I would like to bring your attention to is this one, homelessness. Now, this code went from 4 characters to 5 characters. And why did they do that? Well, they did that because they wanted to specify the type of homelessness. Is it unspecified? We don't really have much information other than the fact that they're homeless. You would use Z59.00. If they are homeless, but they're in a shelter, we would use Z59.01, and we would use Z59.02 if they are unsheltered, they're living on the street. There is a difference in the care maybe somebody's going to get in a shelter versus on the street. Different risk factors, all kinds of stuff. So we really want to know that information if we can. And then we also have some codes from Z59 for other food security, etc. They've added those to that category. Personal history of self-harm, Z91.5. They've expanded that from 4 characters to 5. So now we have personal history of suicidal behavior versus personal history of non-suicidal self-harm. So in the past, we just had this self-harm code. We didn't have enough information to delineate the two. So now you have the two. We're going to do our next one, and this one I'll give you 10 minutes at least, I think, for this one. Here we have a resident who is admitted for PT and OT services after having her right knee joint replaced. The physician documents that the resident received surgery due to osteoarthritis in bilateral knees, and the physician documents that they will replace the right knee only at this time. So I will give you 10 minutes to work on this and look up your codes. So let's look. These are our correct answers. Your principal diagnoses will be Z47.1, aftercare following joint replacement surgery, and then Z96.651, presence of right artificial knee joint. Just make a note that presence of right artificial knee joint code can never be a principal diagnosis. And then we only coded the left knee osteoarthritis. Now, why did we do that? Why did we only code left knee osteoarthritis when the physician documented bilateral osteoarthritis? The reason we did that is once they did the surgery, the osteoarthritis of the right knee was corrected. So this is why we only coded the left. Remember, the physician said both knees had osteoarthritis, but we were only going to do surgery for the right one right now. But the left osteoarthritis is still present. So this is why we only coded osteoarthritis of the left knee. Okay, we're going to break out now and talk about hospital documentation and assignment of ICD-10 codes. And give me 1 second. You know what? I just realized we did not take a break. So let's go through this section of hospital documentation, a few slides, and then I'm going to give you all a 10-minute break. I'm not sure how I passed that, but I do apologize that we did not do our break. So let's just go through the next few slides and then we'll take a break. So when it comes to proper coding, writing up a diagnoses list, assigning the correct code, there's a lot of different things that you have to look at. There's not just one piece of documentation. We look at the discharge summary. So that is the one from the hospital, if they're coming from the hospital. The H&P, the one that comes from the hospital, and the one that our physicians do upon admission. If they were in the ER, we look at those reports. If they had surgery, we look at the surgical reports. We look at the labs. We look at x-rays, MRIs, CT scans, all of those. We also look at physician consults. If they saw a pulmonologist, etc., at the hospital, we're going to want to look at those to get as much information as we can for that diagnoses list. So one of the things that we sometimes see is the stuff that's, the codes. Sometimes they'll list codes, ICD-10 codes, within their documentation, depending on the software used from the hospital. And sometimes those just get copied straight over by our coders. And that is not a good idea. And the reason for that is the physician's going to type in a search term, and a lot of times they're just going to select the first default code they encounter, and that code may not even match their documentation. They may just type in femur fracture and hit the first one, but it's not the level of specificity that they've documented within their narrative. So you want to rely on what they're actually saying, what they're writing down, what they're documenting, not the codes that may happen to get selected. And it says here in some cases, but I'm going to say in most cases, you're going to kind of need to do some investigation so that you're assigning the correct code. And for principal diagnoses, that's another thing you need to keep your eye out. Some facility coders just tend to copy the principal diagnoses from the hospital, and it may not be an active diagnosis because maybe they believe that we are required to use the same principal diagnoses as the hospital, which we are not. So the fiscal year 2019 Skilled Nursing Facility Prospective Payment System Final Rule, it's a mouthful, states that the SNF must be treating a condition that was treated during the qualifying 3-day stay. And then the Medicare Benefit Policy Manual states that a beneficiary in a Medicare Part A SNF stay must require that skilled nursing care for a condition that was treated during the qualifying stay, or for a condition that cropped up while they were being treated in the SNF for treatment of a condition for which they were previously treated in the hospital. And CMS does recognize that in many cases, the primary reason for the stay in the SNF care may not be the primary care reason for a prior inpatient stay. So PDPM requires us in SNFs to code the diagnosis that corresponds most closely to the reason for admission to us, to our facility, to the SNF, for skilled services rather than the primary reason for prior hospitalization. So you want to keep an eye out on that. And here's an example. You have a resident who is hospitalized for cholecystitis, and the hospital treats it with a cholecystectomy, the hospital is going to assign the code for cholecystitis as a principal diagnosis. Once they then come to us, we can't use the code for cholecystitis. They don't even have a gallbladder anymore. They're coming to us for aftercare following that surgery. So we would use the code for encounter for surgical aftercare following surgery on the digestive system. And then we would have a secondary code to identify that the gallbladder was removed. So critical thinking skills, you have to think, okay, why were they in the hospital? Okay, why are they coming to us? And just like that last scenario that we did, where the resident had bilateral osteoarthritis of the knees, but they only replaced the one knee, so the osteoarthritis only was then coded for the untreated knee. So you need to think about those things. And when it comes to your principal diagnoses, I know we mentioned this yesterday, we talked about this. When somebody gets admitted, the best practice is for your IDT to review that medical documentation the day after admission, determine the best principal diagnoses, make sure that it maps to a clinical category for your Part A's, and then give that information, give the principal diagnoses and any skilled diagnoses information to your therapy so that their therapy evals are accurate, and to nursing so that they know what skilled services they are going to be documenting about. So this is really important that from step one that we are all on the same page and everyone has the same information. And it doesn't take that long for you to look through the documentation from the hospital to determine what the principal diagnosis is. If you were to try to code the entire thing, that could be time consuming. But if you're just trying to come up with what is the main reason why they're here, that shouldn't take more than about 10 minutes. Okay, we are going to take a 10-minute break here before I get into queries. So go ahead and get up and stretch, use the restroom, have some coffee, water, whatever you want to do, but we'll come back in about 10 minutes. Okay, break's over. We're going to start back up and we are going to dive into MD queries, physician queries. There are multiple instances why you might want to query a physician, but let's start with talking about query basics. Any query must be clear, it must be precise. You have to present the facts and identify why you need clarification, and you want to present that information to your physician or physician extender without leading them to a particular diagnosis. So part of today's and yesterday's presentation is a query packet, which you will have emailed to you. And I believe there's about 10 of those that are in there, and they cover cardiorespiratory failure and shock, cerebrovascular disease, chronic kidney disease, depression, diabetes, undetermined principal diagnoses, and I imagine that one will get some good use, malnutrition, COPD, the one for your nursing, your treatment nurse, the one we went over today, and then obesity. So you want to be really careful about opportunities to either, I don't want to say, let's just say missed opportunities for coding, where querying could really help you out to where maybe you get some more NTA points. So we have an example here of somebody who has epilepsy. If the epilepsy is documented as being intractable epilepsy is a NTA comorbidity and will get you more reimbursement. So if you have documentation that suggests intractable epilepsy, but it's not really 100% clear, and you just leave it at that and you just don't bother coding it as intractable, or you don't reach out to the physician for clarification, you could miss a potential opportunity for more reimbursement. On the other hand, if you just got, sounds enough like it, and you code intractable epilepsy, but it's not clearly documented, then they could consider that as upcoding and fraud, which we want to avoid at all costs. So it's really a fine line. You want to check your documentation, see if it's clear, and if it's not, especially if it's something that can help you out with an NTA or an SLP comorbidity, you want to make sure that you are taking that opportunity to talk to your physician. Okay. So what is a physician query? It is a communication between you and a physician or physician extender to get additional information that will clarify the specificity of the data that you are going to be using to assign a correct ICD-10 code. Once the physician or physician extender has filled out their portion and answered the question, hopefully resolving your question, they need to sign it and date it. And that query form is going to be filed within the medical record to support that documentation. That's your supportive documentation for the code you will then assign. Other terms for query would be a clarification, clinical clarification, documentation clarification, clinical documentation improvement is a term used in hospitals, CDI. It has to do with physician queries and making sure that we have the correct documentation to support our coding. So when it comes to writing a query or using a query tool, CMS has some advice, and this is what they say. They say, you should use query forms to the extent that it provides clarification and is consistent with other medical record documentation, should be phrased in such a way that the physician can specify the correct diagnoses, should not include impact on reimbursement or quality measures, and should not be designed so that the only thing required is a signature. Let's talk about that third one down. Should not include impact on reimbursement or quality measures. I was just telling you that you're going to use a query in particular for maybe NTA comorbidities where that would impact your reimbursement. That being said, yes, you would want to make sure that you have the correct documentation, but you would not write on the query, hey, doctor, can you document that this person's epilepsy is intractable so we get more money? No, you don't want to mention that within the body of your query. You just want to present it in a way that you are requiring clarification on the clinical documentation so that you can accurately assign a diagnosis code. And again, you don't want to say, doctor, it looks like it's this, please sign. And then you've led them to a diagnosis. You want to avoid that as well. And that is a leading query, which is the slide that we're going to go into. So this is one that is not supported by the clinical elements in the health record, and it directs a physician to a specific diagnosis or procedure. Just like in court, an attorney can't lead a witness into a statement, you also cannot lead a physician to a particular diagnosis. And you have to follow the rules to make sure that you're avoiding leading them to a particular diagnosis. There's different types of queries. You have multiple choice queries, and the ones that we've sent you, or will be sending you, I should say, later on today or tomorrow, will be multiple choice. So these all include additional options such as clinically undetermined or other, and that allows the physician to write a narrative to explain their rationale. You want to make sure that you are not using terms like likely, probable, or possible as options within a query, because that just doesn't help you at all. And there's a link here to a query form. I'm not going to get into that. You will be receiving those. And we already went over the one for licensed nursing, so you have an idea of what those look like and the options that are on there. So here is a multiple choice query. So a patient's admitted for a right hip fracture. The H&P notes that the patient has a history of chronic congestive heart failure. A recent echocardiogram showed left ventricular ejection fraction of 25%. The patient's home medications include metoprolol XL, lisinopril, and Lasix. And you write for the doctor, please document if you agree that the patient has chronic diastolic heart failure. That would not be the way you would want to handle that. So the correct way, the non-leading way to do that would be to write something similar to this. It is noted in the impression of the H&P that the patient has chronic congestive heart failure, and a recent echocardiogram noted under the cardiac review of symptoms reveals an ejection fraction of 25%. Can the chronic heart failure be further specified as, and then you give them options: chronic systolic, chronic diastolic, chronic systolic and diastolic, some other type of heart failure, and undetermined. And the some other type of heart failure, they would be able to write in their rationale if they determined it was something other than what was listed here. But the point is, you want to make sure that you're giving them options to choose from, that you're not just telling them it's this or it's that. So preparing the physician query, you want to obtain or decide on a query form. Fill in the resident specific identifying information, their name, their medical record number, date of birth, all that good stuff. Indicate the reason or the issue why you are requesting a query. Complete the query on or before the MDS 5-day, the assessment reference date. Flag it in the chart or send it for physician completion. So one of the things I wanted to make you aware of and be careful with, I had a facility where there is a query that we have for malnutrition, and the RD, the dietitian, had decided that a query was warranted for this particular resident based on their assessment and what they were seeing, but the physician had not documented malnutrition, but it seemed fairly clear to them that this person seemed as if they may be malnourished. So they filled out a query tool and they stuck it in the medical record. Well, weeks and weeks went by, the physician didn't see it, and nothing was done basically until it was too late. So what we want to be very careful about is that if a query is going to be done, that there is a point person, usually medical records, who is giving that query to the physician, not just throwing it in the medical record, because you have a limited amount of time to get that information back so that you can take that information and assign the correct code. So you want to be really careful about that. I would recommend that you call a physician and you fax it over, and then you can flag it in the chart or however you want to do it, but you want to make sure that it gets done timely and that a point person is aware of it so that it just doesn't lie there and collect dust and it doesn't do us any good. Once the physician has completed the query, you want to forward that to the coder so that they can assign the correct code. Update the diagnoses list, reprint the face sheet, and the MDS may need to be updated too. So it's all about communication. And then you want to make sure that you're keeping your query sheet as part of the medical record for supporting documentation. And therapy may need to know as part of their eval. So you want to just communicate with everyone. And if that medical record is selected for a ADR, make sure that that query goes along with it to show that you are supporting, that you have supportive documentation. And remember, we also went over that one for the treatment nurse, the non-pressure chronic skin ulcer. That should be in the medical record as well. Sequencing of your diagnoses. Section I-8000, that additional active diagnoses section on your MDS, has limited space. It's got about 10 spaces. So you want to make sure that you have the correct diagnoses for your 5-day assessment for PDPM within there. Only code the active diagnoses per the REI manual, and make sure that the correct codes are reflected in the MDS section I, and make sure that all of your NTA diagnoses for section I-8000 and the checkboxes are indicated to correlate for correct reimbursement. So in a nutshell, your sequencing guidance would show, first things first, your principal diagnoses. And this is, we're talking about Medicare A's, PDPM. Your principal diagnoses has to map to a PDPM clinical category and be consistent throughout the documentation. So it should be your MDS principal diagnoses. It should be the principal diagnoses on your UB04. Should be your therapy medical diagnoses. That should be first. Then your NTA and SLP diagnoses. Then your supporting diagnoses for your nursing skilled services, and then your therapy treatment diagnoses would be below that. So ICD-10 coding flow, there's different things that can impact your accurate and timely diagnoses. First thing is, if your diagnoses list isn't done timely, we wait until they've been here a week before we even do that diagnoses list. That's going to be a problem. Remember, we were talking multiple times over yesterday and today about the best practice for PDPM as far as assigning your diagnoses. The best practice is for your IDT to get together in the morning and go over the prior day's admissions and come to a consensus about what is the primary reason for them being in your facility, receiving skilled care, getting therapy. What is that principal diagnosis? Looking it up, making sure it maps, and making sure everyone's on the same page and everyone knows what the principal diagnosis is and what the skilled diagnoses are. If they've got stage 4 pressure ulcers, nursing should know about that so that they are documenting about that. Another thing that can impact your efficient coding workflow would be your physicians aren't responding to your queries, or they don't know about it. So building that rapport with your physicians, making sure that you have a good rapport with their staff, their office staff, to make sure that they get those queries. And then a lack of follow-up to obtain reports from the acute care hospital. You need to have somebody who is responsible for that, Who's going to be in charge of calling that acute care hospital to say, you know what, they had a surgery, but I know they had a surgery, but there's no surgical report, or we're missing the x-rays, or things like that. Now remember, the acute hospital has 14 days to do their discharge summary. Usually it's before that, and some hospitals may have a better turnaround time than others, but somebody needs to be in charge of making sure that we have those reports. So I'm not going to tell you who that has to be. Sometimes I get asked, who's in charge of that? Well, that really is a case-by-case facility problem. You know, I can't determine who that person's going to be, but you want to make sure that you have the right information and that somebody's responsible, because if nobody's responsible, it just won't get done. And then you want to make sure that you're continuing to improve coding in your facility by looking for and correcting your common coding errors, using your query tools as needed, as applicable. And remember, you are our clients and we are here to assist you. So I do have some facilities that I go to, and when they have to write a query, they shoot it my way first. You know what, this is a query I'm writing, how does it look? And then I can take a look at that and maybe offer them advice, or, oh, it looks great, go ahead, send it off. So use your consultant to help you with that, and the query tools that you will be provided that will also help you with that as well. And the other thing you want to make sure that you're doing is updating your diagnoses in your computer at least quarterly, printing your new diagnoses list and your face sheet after those have been updated. One of the things that you want to be looking for is when MDS is doing their quarterly assessment, to take a look and see, are there old stuff? Is there old stuff on here? Do we have, you know, a pneumonia code that goes back 8-10 months? You know, is there something that's completely resolved that shouldn't be on here anymore? Your diagnoses list should be up to date. And I always tell the story of the facility with the 4-page long face sheet. You know, they had I mean, diagnoses going back a decade or more that they never resolved. And it just got, you know, the face sheet just got bigger and bigger and bigger. So we want to make sure that we are keeping those current. Now, when it comes to common coding errors, I'm going to tell you the ones that I see the most. And we'll get into questions in a minute. But for me personally, the ones I see the most are the specificity of the documentation not being carried over into the code. So unfortunately, this happens sometimes when we memorize a code. We think, oh, they've got diabetes. E11.9 is the code for diabetes. It is. It's one of the diabetes codes. There's many. E11.9 is diabetes type 2 with no complications. Now, I'm going to tell you right now, and I'm sure you know, most residents, by the time they get to an age where they are in a skilled nursing facility, not all of them, but a lot of them, and they have diabetes, they have complications by that point. Maybe it's chronic kidney disease. Maybe they've got a foot ulcer. They've got some other skin condition, peripheral vascular disease, neuropathy. So there are usually going to be complications, and you need to keep an eye out for those and make sure you're capturing those. Remember the coding for hypertension, those combo codes. We did one today with hypertension and chronic kidney disease. We want to make sure that we are getting the correct hypertension combo codes, that we are coding the use additional codes. Remember, for infections, if they have an infection, you're going to use one of two different types, either a combo code that includes the infection with the causal organism, or a standalone infection code, which then asks you for a secondary code to identify what that causal organism is. So pay attention to those lab results when they can come in. If you have a resident who's been with you a while, and you know they start having urinary pain or burning, whatever, and they send out a culture for culture and sensitivity, if we're having a new prescription for a new antibiotic, it would behoove us to think, oh, infection, I'm going to go and look at their labs and see if there's a causal organism so that I can code it appropriately. So pay attention to that as well. Another common coding error is coding the acute CVA instead of the sequela of CVA. Be very careful with that. And also using the orthopedic aftercare codes in conjunction with a fracture code. You want to avoid those two together. We went over a scenario with that. We want to be very careful about that. Now I'm going to go over some questions. I'm going to look at what's in the Q&A and chat box. Bernadette, you have a question here that says, for rehab notes, the patient has UTI they cannot use as a primary diagnosis because it's already resolved. I'm not sure if you're asking if they can use AFib as a next primary diagnosis. It would really depend on the scenario. If AFib was a, if it fits the definition of a primary diagnosis, then I would then use it. And then in medical claim, the primary diagnosis of the residents they use. I'm not sure what you mean by that one. If you can clarify that, I can try and address it. Okay, and then I'm going to go over to the chat box here and see what we have. Can you use a Z43 code as a secondary code after removal of a body part? Well, Z43 codes are the artificial opening codes. So I'm not sure what the question is for that one. I'm not sure. Maybe Patricia, can you clarify that question? Z43 codes are attention to an artificial opening, attention to gastrostomy, etc. And then the next one is Logan. Resident had a fall from bed with a right femoral laceration and was transferred to the ER. They came back to the facility the same day. What will be the correct code for fall and laceration? I don't have my code book. I mean, I can do what I tell you not to do, which is Google. But you would code the laceration, and then I believe the fall code would be the R29 or R59.6. I have to look it up. 1 second. So the fall code, you can use R29.6, and then the laceration, I'm assuming that's femoral artery laceration. And that is an S75 code. So, but that being said, there's a code for a major laceration of a femoral artery and a minor laceration of a femoral artery. I imagine if they came back the same day, it's a minor one, which would be S75.012D. A major laceration of a femoral artery would probably, you'd bleed out. So you might want to query the physician, but I imagine that they would probably document that. Query for physician if compression fracture of the lumbar is pathologic or traumatic. Okay, compression, is it correct if pathologic should be coded as traumatic? Oh, I'm not sure what you mean by that, Bernadette. I'm not sure. Usually they'll mention some sort of trauma though, if it's traumatic, like they fell or something along those lines. If it's completely out of the blue and you have no idea, you would need to query the physician. In sequencing of the diagnoses on the face sheet, the medical management, first therapy, treatment, and return to provider. Is that the order? I don't know what you mean by order. I think unless you're trying to talk about sequencing. So when it comes to sequencing, if that's what you're asking, you want to make sure that your principal diagnosis maps to a clinical category. Medical management is a clinical category. So that could be your principal diagnoses. Therapy treatment codes can never be your principal diagnoses. That would be after all your NTA and SLP comorbidities. And return to provider is you cannot use it as a principal diagnosis. You can use return to provider codes as secondary codes, because a lot of your therapy codes, for instance, like M6281, your therapy treatment code for muscle weakness, that is a return to provider code. That doesn't mean we can't use it. We just cannot use it as a principal diagnosis. I hope that answered your question. Logan writes, if the principal diagnosis is pneumonia and patient becomes long-term, do we resolve the pneumonia now, even if it was a principal diagnosis? If they're going to continue with long-term care, you want to list the diagnoses of why they're staying long-term. Maybe it's Parkinson's, whatever. Yeah, the pneumonia would get resolved. And for principal, removal of part of the colon, then secondary is attention to the colostomy. Oh, okay. So Patricia, you're asking how you would code that. So if somebody had a surgery to remove part of the colon, then you could have, it depends on the situation. Remember earlier I was saying if somebody has colon cancer and they're removing a colon mass, then it would be aftercare following surgery for neoplasm. But if they're just removing part of a diseased colon, maybe they had some sort of necrosis of the colon and they had to remove part of it, and that happens due to some conditions, then it would be aftercare following surgery on the digestive system. And then then you would have absence of a digestive organ as another code, and then you would have attention to colostomy, yes, as a secondary code, second or third code down. Oh, how soon can we use Z86.16? That is the history of COVID-19, assuming patient is asymptomatic and off from isolation. I would think I would use that. I mean, you're probably not updating codes all the time, but when that quarterly review comes around, you would add it on there. That's what I would do. This Omicron variant is kind of throwing everyone for a loop because you can be infected multiple times. It's just crazy. So as far as I know, there's no hard and fast rules of that, but I would try and review my diagnoses list quarterly at minimum. Okay, I'm going to move over to Q&A. This one was the one I didn't quite understand. Okay. With a THA after a fracture, I know I've got some coded Z47.1 as primary. Should I go back and fix them or do it correctly going forward? Susan, my answer to that question is, I would do it going forward. If it's recent, if it's a recent one, they just got admitted recently, you can adjust it, you haven't billed for it, then yeah, I would try and correct it. When I go into a facility, I always try and look at the ones that we can still fix. Those are the ones I'm going to focus on, because once you build it, it's, that's a whole other animal. And I believe you might have to do a change to your MDS. I don't know all the ins and outs of that, but I would try and go back, try and go forward and do it correctly. And then if I have any that were recently admitted, I try and fix those. What is the difference between admission and principal diagnoses? Those can sometimes be the same. And I think, Logan, you were asking earlier about the one for if somebody was admitted with pneumonia. If you feel they're going to be there a long time, I think sometimes some systems won't let you change the admission diagnoses. The admission one, I might want to put the diagnoses of what's going to keep them in the facility. Maybe they have Parkinson's, something like that. And then the principal, I would put maybe the pneumonia. If you were trying to kind of tie those two together, possibly that's what I would do. Okay. Anonymous says, do we need a physician statement that a diagnosis is resolved in order to remove it from the diagnoses list, or is non-treatment enough to support the removal? I don't know. If we are chasing after our doctors, you need to resolve this, nothing would ever get done, right? They're busy enough as it is. So no, I don't believe that a physician statement that something is resolved is needed to remove it. If we're just not treating it anymore, I would not code it. Now, be careful about some chronic conditions. Sometimes people have a chronic condition that is not going to get any better. It's not going to resolve. It's not going to get any better, but maybe, you know, the treatment has changed more to monitoring than resolving it altogether. So for instance, if you have somebody with diabetes and they were on insulin and through, you know, diet and exercise and all that good stuff, now they just, all we're doing is monitoring it. I would be very, very cautious about resolving that. Let me go back to the chat function. Bernadette says, patient came in our facility with bilateral primary osteoarthritis in the knees. Can we use as a primary diagnosis in the long term? I don't see why not. I don't believe those are return to provider. So I don't see why that would be a problem. Do we have any other questions before I start to wrap it up? We're not quite done yet. I just wanted to go over a few things with you. Oh, we got more here. Oh, I don't see anything else. Okay. Strange. Okay, I saw pop up and then nothing was there. Okay, so you will be receiving when you go to click out today, a pop-up is going to pop up on your screen, and in that pop-up will be an evaluation for yesterday and today. It will be an evaluation. Once you complete that, you also get a post test. So when you do the post test and you do the eval, then you'll get emailed to you your CEUs if you need CEUs, or a certificate of completion. And then you will receive in a separate email the query samples, the set of queries that I had mentioned earlier. That'll be part of that. That will be emailed to you. Marlo, I'm going to answer your question in 1 second. Let me just finish this thought. Additionally, you were provided with a handout. Now, the handout you were provided does not have any of the answers to the coding scenarios that we've worked on yesterday or today. We want to make sure that you have that correct information. So you will be also receiving an email with the complete handouts, all the slides with the answers to those questions that we reviewed. And also part of those answers, it will also go over the rationale for the reason why they were answered the way they were. Okay, so I have a question here from Marlo. Marlo is asking, patient admitted into the facility with status post right hemiarthroplasty due to right hip fracture related to mechanical fall. This is that tricky one that I was really trying to hammer home with you guys. Code the femur fracture first, and then your secondary code will be presence of right artificial hip, and then you can also use the fall code. So you would use the S code, the fracture code as the primary. Your secondary code will be a Z96.6 code saying presence of right artificial hip, and that makes it a complete, it makes it complete. The claim will be complete. It shows what happened. Marlo saying we cannot use Z47.1. No, you can't. They had a fracture. Fractures trump everything. If there is a fracture, whether it is a traumatic fracture or a pathologic fracture, those fracture codes have a 7th character delineation for encounter, initial encounter, subsequent encounter. And when you have those type of codes, you cannot then use an aftercare Z code at the same time. You have to code the fracture. That's your main one. Let's see. Something about here, patient has 5 cardiovascular codes. How do we sequence it? I don't know what the codes are, specifically what you're asking. Bernadette, I'm going to ask you to send that information to my email, alicia@ahis.net. Specifically, and I can take a look at that particular scenario. There's a lot of different I just typed it on the screen there for you, Bernadette. So you can email me your particular question with the information on that particular resident, and I can help you because that's kind of vague and it's a little bit difficult for me to answer that question. So, oh, you're welcome, Marlo. Okay, so it looks like we have answered all the questions that you all had. So remember, you're going to get a pop-up with the link to do your eval, your post-test, all that good stuff. If you miss it, if you didn't do the pop-up or you're just, dying to get to lunch, I get it. It's, time for lunch. You will also get that email sent to you separately. That link will be sent to you separately. Oh, Bernadette, what's your question? Unless you're just asking me what my email address. Oh, in a Part B claim, can we use M code as primary? There's a lot of different M codes. Like that's a whole chapter. So can you send me that information to my email, Bernadette, so I can help you with that? M170. I don't have my code book. Okay, I don't want to hold everyone up for one question, so I will say we're going to end it here. Bernadette, I will answer your question via email. I'm trying to look that up, and I don't want to keep everyone behind for one question that's specific. Bilateral primary osteoarthritis. Yes, I believe you can use that as a primary. I don't see why you wouldn't be able to, so long as it maps to a clinical category. Okay, thank you all so much for your attention. Don't forget to do your post-test and your evals, and have a great day, and please be safe and take care of yourself. And we will also periodically send you emails with more information for future webinars. Take care.